current presentation will cover the concept 35 from your concepts book, referring to the cognition. You probably heard the words of the French philosopher René Descartes. He said, cogito ergo sum. It's in Latin, and it translates by I think, therefore I am. In other words, the ability of thinking is considered a defining characteristic of being human. In order to understand cognition, and definitely for studying it, we need to look at it from a multitude of multiple angles, and it will become a multidisciplinary way of looking at it. And we can involve psychologists and philosophers and neuroscientists or linguists, and even artificial intelligence scientists will have a say in talking about cognition. There are two fields that are exclusively dedicated to the study of cognition, and those are cognitive psychology and cognitive neuroscience. While cognitive psychology is dedicated to study of cognition from an information processing perspective, it means how do information that is received by the brain is processed and used. The cognitive neuroscience, it combines the study of mind and the brain, is looking more in depth and is establishing it's studying the same type of processes from a more in-depth at the level of neurotransmitters and structures of the brain. Please pause the current presentation in order to review the learning objectives for this presentation. We'll start, just like in previous presentations, by defining the term of cognition. And you can understand by now that cognition is a very wide term and is used, and it refers to the processes that will involve the human thought. So those processes will also be related to the reception of information, to everything that our brain receives, the sensory input. The process is dependent on the ability of the brain of processing the information, and sometimes it's not just the brain, there are some other structures in our nervous system that are involved. Will involve a certain amount of storage of the information, and while I'm storing something, I need to be able to retrieve and bring it back, the retrieval of the information, and also to the ability of the brain to use the information. So in other words, the cognition will be defined as the mental action or the process of acquiring knowledge and also understanding through thought, experience, and senses. There are 6 domains of cognitive function, and those will include motor function, language, learning and memory, social cognition, complex attention, and the executive functions. 3 are related. There will be the perception, the memory, and the executive function. And I think that those are important to be defined and described a little bit more in depth. The perception is that interpretation of the environment. You heard probably numerous times people telling to you, it's a matter of perception. It's not what you think. You are perceiving the information in that way. So the perception is how we interpret the environment, and is dependent on the ability of perceiving the information, or in high words, we'll say the acuity of the sensory input, how well I am able to receive the input from the outside. Related to that, we have another concept that is called the concept of awareness or the consciousness. And that will represent the ability of an individual to perceive or be sensitive to stimuli in their own environment, and based on that, respond to them. So part of this awareness or consciousness is the attention. And the attention is that focused part of the awareness or consciousness that will be focused on a particular area of content. Now let's see how we can define memory. So memory, if we really want to have a wide way of defining it, we can say that it's simply the retention and recall of any past experiences and learnings. However, it's a little bit more complicated than just that. And there are a different number of subsystems that will support different types of memory. And may have, because of that, may have what is called episodic memory. We remember just bits and pieces of some of the events. We have the declarative or semantic memory. We have the immediate memory. We can have the working memory, and we can have the procedural memory. Remember that I said declarative? Let's look into that. Declarative will refer to the ability to, in a conscious way, to learn and recall information. And not just because it comes back kind of a muscle memory of the brain, but because you are bringing it back on a conscious way and you are processing it. On the other hand, you have the declarative or semantic memory that refers to the memory of knowledge or words or facts. It's pretty much the memory that we are using when we are learning by heart a poem. Sometimes the declarative memory can provide for very long-term storage of large amounts of information. I was saying also, if you remember, I was talking about the working memory. Working memory is that part of the memory that allows for a small amount of information, very, very limited, very meaningful units, to be actively maintained and manipulated for a short period of time. The procedural memory, on the other hand, refers to the retention and retrieval of some motor skills. So for those of you guys that are hands-on type of learners, you are using mainly your procedural memory. However, in order for this memory to be efficient, it requires extensive training, and as well it provides for a long-term storage of a moderate amount of information. I was talking before that we need to discuss not only about perception and memory, but also about what is called the executive function. The executive function will refer to the higher thinking process that allows you, through flexibility, adaptability, to aim towards a goal. So the executive function will determine the content of the consciousness and will supervise our voluntary activity. And executive function is future-oriented. Executive function will be deciding in which order and how to perform your work in order to be efficient and be able to attend to all the elements that you had on your list for the day. What is the scope and the categories of the cognitive? So we are going from cognitive to higher order cognitive functioning. So let's try and describe those elements. If we are looking at a very basic level of how we can describe cognition, the cognition can be either intact, good to go, functioning, or impaired. In an intact condition, all the characteristics, the cognitive behaviors that an individual will exhibit will be in the normal range and acceptable range for their age and the culture of that person. An impaired cognition, on the other hand, will be an observable or measurable disturbance in one or more of the cognitive processes. And that can be a result of an abnormality within the brain or due to any type of factor that will interfere with the normal brain function. So in other words, the cognition represents a continuum. And it's not a matter of all or none. It can change over time, and the degree of the impairment can be mild to severe when we are talking just about the cognition. In other words, in the second type of classification of impairment can be seen from a temporal point of view, from a time perspective, and they can be either temporary, present for a very limited period of time, or they can be chronic, or can have a permanent state. Let's take a look now at the neurophysiological process that involves the concept of cognition. So we started the lecture by saying that cognition is defining for humans. And this is when we are comparing us humans with any other forms of life. Whenever there is no injury of the level of the nervous system, the cognitive development will be established and will continue throughout our lifespan. It's improved and increased during infancy and through adolescence, and less traumatic changes will happen during our adulthood years. Now, let's remember a little bit the anatomy and what is involved in the process of cognition in terms of structures of the body. So we have 4 major units at the level of the human brain, and those will be the cerebrum, the encephalon, the brainstem, and the cerebellum. Definitely the brain is the element, the part of our body where multiple processes, including purposeful thoughts and responses, will happen. In addition to that, at the same level of the brain will have all those involuntary or without purpose thoughts that will involve coordination of breathing or heart rate, reflexes, temperature regulation, or hormonal control. Obviously, most of the cognitive tasks will take place at the level of the cerebrum. If you remember, the cerebrum is divided in 2 hemispheres, the right and the left, and each of those 2 hemispheres will have 4 lobes: the frontal lobe, parietal lobe, temporal lobe, and occipital lobe, that they correspond to the same bones in the skull. Another structure that supports and it's part of the cognition, but it's seen as a supporting system, is the limbic system. And this structure will overlap the cerebrum and the encephalon. We have a few advanced functions of the brain, and those will be the intellectual functioning, the ability to reason, the ability to express personality, and the purposefully interaction with the external environment. All of those functions are carried out by the cerebral cortex. In other words, our brain is continuously involved receiving internal and external data signals, and those will be integrated. By integration means will be received and sorted out, interpreted, will be understood, and those elements that need a response will generate an either sensory or motor response. Another part of the brain that is involved in the cognitive process is the hippocampus, which is part of the limbic system that plays a significant role in being involved with the long-term memory. Optimal brain function depends on an accurate and continuous perfusion, and the perfusion, the blood flow, will bring in the oxygen and the nutrients. Please remember from anatomy that the brain is not able to use any other source of energy, is not able, like other structures in our body, to perform in an anaerobic break of glucose for generating energy. In other words, our brain is highly dependent both on the circulation and depends on having adequate levels of oxygen as well as glucose. There will be certain age-related differences, and as usual, we will look into those age categories that are the extreme sides of age as infants and children versus older adults. As you can imagine and actually know, most of the cognitive development occurs during infancy and in childhood. Once we are born as newborns, the brainstem and the spinal cord are fully developed. However, the limbic system and the cerebral cortex are still not having the structure that they will have in our adult life. And I'm not talking now only about the size of those structures. I'm also referring to how many circumvolutions they have. So it's not just size. So a newborn infant has a certain type of behavior, which is embedded and controlled by the lower brain, by the more primitive structures of the brain. And those structures will look over the sleeping, the crying or feeding, the ability and the normal reflex of sucking and kicking, all those reflex behaviors that are innate, and we do share them with other creatures in the nature. Piaget, if you remember this psychologist, he looked into the process of the cognitive development and described it from infancy through childhood and even in the adulthood. So in his theory, if you remember, the cognitive development has to follow a very strict order, and it goes through very well-defined sequences. Those will be 4 stages. We have a sensory motor one that defines us from birth to age 2. We have a pre-operational one between age 2 and 7. We have what is called the concrete operational stage between 7 and 11 years of age. And we have the formal operational stage that starts at age 11 and continues throughout our life. Now, those will be the way that our brain functions. But what will be the physiological elements that contribute to this development and to a correct transition from one sequence to the other? There will be 3 essential changes while our brain develops. One will be the increase in the brain mass. The second will be an increase in the number of the synapses that connect the neurons in our brain. And the third one will be an increase of the myelination of the nerves axons. If you remember, by myelination, the speed of transmission of the impulses is increased. So our brain will continue to grow through the infancy and childhood, and some recent studies will show that actually our brain doesn't stop growing and continues, especially the frontal lobes, to develop until late into adolescence, and sometimes it is not fully developed until age 21. As a fun fact, if you want, our brain mass triples in weight during the first year and represents the single greatest change in brain size after birth. Again, along with this increase in the mass brain, we'll have an increased number of neurons that will increase the number of connections. That increase in synapses and connection between those neurons between age birth and age 2 is massive. It's like an explosion. And now you'll understand why you hear all the time that children need to be exposed to stimuli, any kind, visual and auditory and smells and taste, regardless what types of stimuli, they need to be exposed to them, because all that exposure will allow their brain to develop and their synapses to create more connections. So the connections will happen in different regions of the cerebral cortex. They may happen at the level of the sensorial cortex or the temporal lobes or the frontal lobes. And along with those developments, we will register certain milestone achievements. And by observing the effect of this development, of the physiological effect, we can consider that those milestones that we know that they need to be achieved were completed. Again, myelination is essential, is that fatty myelin sheath that will develop around the nerve fibers. And by doing that, the neurotransmission of the signals throughout the axons becomes quicker, becomes faster and more efficient. So if those are the changes that we see and expect to happen in infants and children, what will be some changes in older adults? Well, with aging, the size and weight of the brain, and as well with the number of neurons, will decrease. And the reduction in and the atrophy of the neurons, as a result of that, we'll see less efficient neurotransmission and slowing of the neural responses. And as a result of that, all the behavior, all the cognition elements will be less efficient and slower. Now, the fact that the mass of the brain will decrease and the number of the neurons decreases with age doesn't mean necessarily in all the individuals that they will lose their cognitive function. So what I'm trying to say is that the cognitive impairment or the intellectual loss is not necessarily a part of normal aging. It's most cases will be an alarm sign or part of a condition, of a disease. There is no such thing as the saying that you cannot teach an old dog new tricks. That doesn't apply to humans. Us humans have the ability to continue to learn regardless of our age. And the more that we will exercise our brain, the more we are able to use it and to continue to perform until a very advanced age. However, there is seen a decline in memory that is associated with aging. However, the extent and the degree of this memory loss, it's highly variable depending on the individual. We'll take a look now at some of the variations and how do we apply the concept of cognition in the context of our patients. So we will definitely look at the impairment of the cognitive abilities. And this is a general definition, will refer as a deficit in intellectual functioning. And nowadays we estimate that more than 16 million people across the United States have some degree of cognitive impairment, and there is a wide range of categories that can be involved and have one or more cognitive impairment elements. Let's try and look into some of those and define them and see how they express themselves in a patient. We'll start with delirium, and let's define this condition. Delirium represents a state of disturbed consciousness. There is an altered cognition with a rapid onset and most of the time over hours or a few days. Whenever an individual is in a state of delirium, they have a dulled awareness of their environment. In other words, they do not perceive, they do not observe the environment the same way that the reality is. They have a disturbed perception of reality. They have a very reduced ability to focus, sustain, or shift attention. Their memory and judgment are impaired, and they are most of the time disoriented. They don't know where they are in terms of space or time. Their speech may be rapid, rambling, and sometimes incoherent. They may show sudden and very intense emotional swings. They can be extremely happy and suddenly become very sad and crying. They may have hallucinations. They may have vivid dreams, and sometimes delusions may occur. very common for delirium patient is that they are restless. In some cases, their activity may be normal or reduced, but very characteristic is restlessness. Delirium is considered the most frequent complication of hospitalization in the elderly population. And this is due to a number of other underlying conditions that will hyperstimulate some areas of the brain and will produce this state of cognition. Those other conditions may be dehydration, electrolyte imbalances, fever, hypoxia, sleep deprivation, some adverse effects of medications, and illicit drugs. In some cases, all those elements and the symptom of delirium may be an initial symptom for a life-threatening condition, such as in elderly pneumonia or urosepsis, and sometimes myocardial infarction can be. So whenever one of your patients will start exhibiting signs and symptoms of delirium, think also that you may need to rule out a physiological condition as well. Neurocognitive disorders, NCDs, refer to a group of conditions that you usually know is classified as dementia. And we call them neurocognitive disorders, and we group them together because they share some elements. They have an acquired and progressive deterioration of all cognitive functions. However, there is no disturbance in consciousness or perception. Your patients will be conscious, will be able to perceive. However, their cognitive functions are declining. They will have memory and judgment declining. They have less ability to calculate. They will have less attention span, and their abstract thinking will be completely inefficient. Those symptoms can show up over a period of months to years. We have two types of dementia. We have the primary dementia, which is irreversible, and is called primary because it doesn't happen secondary to another condition. And we have what is called the secondary dementia that is a result of another disease process. For example, a secondary dementia can be the result of alcoholism. We have those diseases are categorized into subtypes, and they will include Alzheimer's disease and Parkinson and HIV infection, Huntington disease. All of those will end up having a certain degree of dementia. Now, because we have the neurocognitive disorders that are classified as dementia, we have another category of conditions that are classified as cognitive impairment that is not dementia. Those will show a greater reduction of cognitive function than is expected for an individual at their age and education. However, that do not interfere with their functional ability. In other words, this is not necessarily a medical diagnosis, but a state. And it's recognized as being a certain state between normal cognitive and true cognitive impairment. It's like kind of in between. Those individuals that have mild cognitive impairment are at a higher risk, obviously, for developing and progressive into dementia than compared to the other in the general population. We have another category that is called the focal cognitive disorders that affect one single area of the cognitive function. So as opposed to delirium or dementia that have more than one cognitive function involved, in those focal cognitive disorders, we have just one area. It may be just memory or language or executive functions. An example for memory will be the amnesic disorder. And the amnesic disorder is characterized by an inability to acquire new knowledge by they are not able to learn and recall new information. In the same variation of the context, we may have the intellectual disability, and this refers to a limitation of cognitive functions. And usually we are talking about the IQ, and we are referring to those individuals that have a below average intelligence, where the IQ score will be under 70. In addition to their cognitive functioning, they have limitation in conceptual skills or social skills. And due to this lower IQ, they may have inabilities to perform activities of daily living. We have the intellectual disability can be classified as mild when the IQ is between 55 and 70, and most of the population with an intellectual disability will be in this category. We have the moderate intellectual disability with IQ scores between 40 and 55. About 10% of the population will be in this category. And we have those with severe intellectual disability that their IQ scores are between 25 and 40, and sometimes profound under 25. And those will make up for about 5% together, 5% of the population. There are some conditions, especially those that have chromosomal abnormalities as Down syndrome, Fragile X syndrome, or Tay Sachs, that are associated with a certain degree of intellectual disability. In the same context, we have the learning disabilities. They are most common identified and diagnosed during childhood. In this category are those individuals that are challenged, have found difficult to receive the signals, the stimuli, and to process the information that is received. Consequences. Depending on the degree of the cognitive impairment, those can be the consequences can be definitely devastating, and not only for the affected person, but also for the family and the friends surrounding them. Due to cognitive impairment, one individual can be placed at significant risk for a multitude of events, physical, physiological, and social sometimes. They have a high risk to injury due to falls, especially those patients that have dementia, any other injuries inside the environment. They have a higher risk and incidence of hospitalization and long-term care. Most of the time, they will need assistive services and help with their daily living activities. We'll discuss now the risk factors from 2 points of view. What will be the populations at risk, and as well as what will be some individual risk factors for developing a cognitive impairment condition. It is important to define and understand those risk factors, because based on recognition of those elements, we can create the preventive interventions that can modify those risk factors, and by doing that, preventing development of cognitive impairment. When we are looking at the populations at risk, first of all, we will go and identify as advancing age. The elderly will have one of the greatest risks. There are different studies that were done. We're not able to find any kind of differences across population based on their race or ethnicity or gender. However, there is some differences between at level of the when we are looking at the gender. We found that women are overall have a poor health status, dependency, and lack of social support, and insomnia as associated significant risk factors for developing a cognitive impairment condition. While on the other hand, when we are looking at specific for men risk factors associated with cognitive impairment, we'll see that those will include stroke and diabetes. Let's define a few of the individual. Most common factors will be behaviors or environmental exposure, congenital or genetic conditions, and other comorbidities. Let's look into the personal behaviors that can predispose and generate development of an cognitive impairment condition. Will be exposure to chemicals and the traumatic injury to the brain. In terms of high-risk behaviors, obviously we can write down here substance abuse, any type of substance. It can be alcohol, amphetamines, cannabis, cocaine, hallucinogens, opioids, sedatives, hypnotics, any kind of substance abuse. Those that are participating in high-risk activities, high risk for traumatic brain injury, especially those that are not wearing a helmet. And we can put in that beside the football players, which is proven nowadays that they develop dementia at a very young age because of the repeated microtrauma that they suffer, despite of the increasing changes in the development of their helmets, trying to protect them better. We can include here as well skiing and cycling, motorcycle riding, and those people that are doing the rock climbing, most of them will not wear helmet. In addition to that, will be those that are not wearing a seatbelt or seat restraint in cases of children when riding vehicles. And we can add to this category any type of accidental injuries associated with work or violence, even in the absence of the high-risk behaviors. Some environmental exposures that can increase the risk of cognitive impairment will be exposure to old lead-based paint, especially in children, is known to produce modification at the level of the brain and preventing their normal brain development. Another type of environmental exposure will be the chemical agents as pesticides. Congenital factors and genetic conditions. Again, just to put it in perspective, congenital means present at birth, while genetic is a condition that is inherited from the parents. The difference between them, another one will be that congenital is always present at birth and may not be inherited from the parents. However, a genetic condition is present at birth, is inherited from the parents. It may not give any signs until later in life. Most of the conditions that are genetic or congenital will have a certain degree of impaired cognition. Let's say related to maternal conditions we can mention the fetal alcohol syndrome or cocaine or methamphetamine exposure. Some are caused by birth injuries, as in cerebral palsy. And in terms of chromosomal abnormalities, like I was naming before, would be the Down syndrome or Fragile X, Huntington disease. There is a long list of genetic conditions. Physical disability and reduced mobility is another individual risk factors. There is that looks to that there is a relationship between physical disability and decline in the cognitive function. Other health conditions as comorbidities, there is a long list of conditions that may be associated with cognitive impairment that can be either temporary or long-term. And we can name here fluid and electrolyte imbalances, any type of systemic or intracranial infections, fever or pain, hypoglycemia, anoxia. All those can be elements that you can see delirium showing up, which is most of the time reversible delirium if the treatment is instituted immediately. Stroke and intracranial tumors can also cause cognitive impairment. Most of the time, this is irreversible and long-term. Other chronic conditions as cardiovascular disease or chronic pulmonary disease or depression, they can be also seen and associated with a decrease in the cognitive abilities, one or more. In terms of assessment, it is essential, first of all, to emphasize that when we are evaluating a normal, so-called normal cognitive status in an individual, we need to define and understand their stage of development. There is a certain expected cognitive development for an infant or a young child as opposed to an adult or an elderly. And as in any other case, we will start with the history. And we will need to discuss this based on the category of your individual. Let's talk about it. We'll start with the adults. And we always, the cognitive functioning is always and should be always a part of the health history that you're gaining from from your clients. The first and the easiest one is to assess their level of consciousness, because unless the patient is fully aware of the self and the environment, any other cognitive assessment may not be valid. So when we are assessing during the history an adult, we need to make sure and observe that they are alert and awake and they have appropriate responses when they are introduced, and they have appropriate responses to their environment. We'll observe the speech pattern and content, the memory logic, and the judgment when we are having a conversation. So what can be some questions that we ask during history? We'll need to inquire about any type of history of intracranial disease or trauma, of substance abuse, any type of use of any kind of medication use that can impair cognition. What is the environmental or occupational exposure to hazards as lead or insecticides, pesticides? All those elements are essential and can guide us in our evaluation. If any abnormalities throughout the history are noted, we'll need to go into more specific cognitive assessments. When we are evaluating an infant or child, the parents need to be inquired about all the prenatal and birth history, in addition to the health history that we are usually inquiring about, and that needs to go back for 3 generations. We are going back to the parents, grandparents, and great-grandparents, as much information as possible, especially if we are suspecting any type of genetic conditions. When we are examining, after the history, we'll go into the examination state, and we will look for general appearance, behavior, and cognitive functions. So in terms of general appearance, those can give us clue regarding the individual cognitive functioning. We are looking how is the posture and how are the body movements. If they are relaxed or coordinating and smooth, or they are slumped and slow movement or dragging their feet, we will observe for patients dress and overall hygiene. And we need to consider that and evaluate if it's appropriate for the setting, for the gender and age, and the weather. Definitely, someone that has a cognitive impairment may have inappropriate dress and poor hygiene. In terms of behavior, this will give us clues regarding the level of consciousness. An individual should be awake and alert and aware of their environment. In terms of abnormal elements regarding behavior or the level of consciousness, we'll have an individual that is lethargic or exhibiting stupor or confusion. Regarding behavior, their facial expression should be appropriate and consistent with the situation. Whenever we see someone with a flat expression, not showing a lot of emotions, that can be associated with dementia. We will also observe the quality of speech. And the conversations should be fluent and articulate and have the normal and moderate pace. Someone that has an impaired cognition may have trouble recalling words, blocking, may have a distorted speech and disconnected sentences, or they may have a different rate than normal, can speak too fast or too slow. How do we assess now the cognitive function? So the formal assessment will include a test of orientation, and we orient our patients. We try to define if they are oriented to person, place, time. We'll also evaluate the attention, memory, judgment, insight, spatial perception, calculation, abstract reasoning, thought process, and content. You can see that that's a long list of elements that are all related to the cognitive functions. Typically, we consider that an individual is aware, is oriented if it's aware of the date, time, and location. One tool that can be used is called the mini mental state exam, and it consists of 11 cognitive tests that cover the categories of time orientation and place, immediate recall, short-term memory recall, a serial of sevens, in which the patient is asked to count um, by seven, reading, writing, drawing, and the verbal motor comprehension. Usually, this should be a very short test, not more than 10 minutes, and it's very simple to administer. Um, the lower the score, and the total for the score for the mini mental state exam is 30. The lower the score, the more severe the impairment. If you have an individual that scores below 27, they will need referral for further evaluation. What will be now some diagnostic tests? Well, unfortunately, there are no lab tests that can diagnose a cognitive impairment. Um, the brain imaging techniques such as magnetic resonance imaging, the MRI, and PET tomography, they can identify some brain abnormalities, um, for example, tumors or areas of infarcts associated with vascular dementia after stroke, or frontotemporal lobe atrophy. However, they are very limited because they do not correlate well to the level of cognitive impairment. Clinical management. So from a nursing point of view, we have four major areas of concern when we are talking about the cognitive status. We need to recognize the risk for impaired cognition. We need to have a cognitive assessment. We need to have planning and delivery of individualized care when there is, once the level of cognitive ability is established, and to evaluate the outcomes. Now, let's look into the primary prevention, and obviously, primary prevention is preventing um, the development of any kind of cognitive impairment by promoting, and how we can do that. First of all, will be by promoting a healthy lifestyle, by um, discussing with the patients way in advance before they are at an age that um, um, the cognitive impairment can show up, about optimal nutrition, exercise, having a social activity, having regular medical care that can prevent or manage any type of comorbidities, avoiding the use and abuse of any kind of substances, and especially during pregnancy, to protect the fetus. Another way that primary prevention can be used is by genetic counseling for those that are carrier of any genes that may develop any kind of cognitive impairment in their offspring. In terms of primary prevention that are specific to delirium, we'll need to educate our staff in order to recognize the symptoms very, very quick. And we know from a lot of studies that were done in the field that increased risk for delirium will be the use of sleeping medication in elderly patients hospitalized, the use of urinary bladder catheters, and immobilization of the same type of patients. The secondary type of prevention will be the screening or recognition, finding and recognizing as soon as possible any type of cognitive impairment. And this can be done by a periodic assessment of very specific population groups in order to detect any early onset of the condition. The screening is easy to perform, especially for those elderly or aging population, by using the mini mental state examination. We'll discuss now the collaborative interventions, and it's obviously the condition cognition is recognized and interferes with areas of activity of all the areas of activity in healthcare, and it's critical in communicating with the patient and the ability of defining what will be the care necessary for that individual as well. The focus of the treatment will change and will vary depending on the underlying cause of the cognitive impairment, and if this cognitive impairment is temporary or permanent. By saying that, let's say the management of a child with intellectual disability will be different than one of the care for an older adult with dementia or with an adult that has a delirium as a result of substance abuse. However, it's an interdisciplinary treatment and will involve, beside your primary care physicians and nurses, nutritional consulting, speech and language when needed, audiology, home health, and counseling. What will be some general management strategies? We will try and educate our patients in promoting adequate rest through sleep, a good fluid intake to prevent dehydration and electrolyte imbalances, good elimination and pain control, as well as comfort in order to prevent development of any type of cognitive impairment. Also, for some of our patients, it's essential to keep an appropriate level of environmental stimulation because some excessive stimulation can increase the level of agitation and confusion in our patients, as well as the lack of stimulation will result in what is called sensory deprivation effects and withdrawal. Most of the patients with cognitive impairment have benefit greatly from having very predictable routines and staying on very well-established schedules. They need consistent caregivers. They need to be given very simple instructions. We need to keep an eye contact, and they need to be in the presence of familiar people and objects. Please keep in mind that most of them will need sensory aids as eyeglasses and hearing aids, and this in order to maximize their accurate sensory input. We will try and verbally reorient them to time and place. A clock, a calendar should be in their easy way to see. Whenever a patient has delirium and is agitated, we will offer a private room, soft music, any type of relaxation tapes or massage can be helpful. No matter what, safety will be a priority concern for all the patients with cognitive impairment. And their needs in terms of safety will be different based on their developmental status, the degree of impairment, and the person's age. We prefer not to have elderly patients with cognitive impairment drive, use machinery, handle firearms, or be in an environment that potentially has contained hazards. In some of the cases with those that they have increased cognitive impairment, even kitchen can be a dangerous place for them. Pharmacotherapy or the use of drugs in the collaborative intervention can be done in order to treat associated diseases or to control some behavioral alteration as sleeplessness or anxiety, agitation, and depression. On the other hand, we have another type of medication that is aimed for maintaining the existing cognitive function and slow the disease progress and increasing the impairment, the cognitive impairment. We do that in Alzheimer's disease by using cholinesterase inhibitors or glutamate receptor antagonists. We currently have on the market 3 cholinesterase inhibitors approved by FDA. One of them is Aricept or Donepezil, Exelon, which is rivastigmine, and Rezadine, which is galantamine. All of them have been proven to increase the memory, the ability of thinking and speaking skills for a few months to a few years in those patients with mild to moderate Alzheimer's disease. Memantadine or Namenda is a glutamate receptor antagonist. that will delay the functional decline in moderate to severe conditions. Let's look into those. Take a moment and look at the image to see how many interrelated concepts will be involved in the process of conditions. Delirium and Alzheimer's disease, those are two conditions that we already mentioned before. I will define a few of others really quick. The Lewy body's dementia is a type of synucleidopathy that is characterized by a formation of balloon-like protein structures inside the neurons. It's a degeneration of the neurons, in other words, um, um, at the level of the brain, and it's the third most common form of dementia. Vascular dementia, or the vascular cognitive impairment, is the second most common type of dementia as a result of damage to the cerebral blood vessels, and as a result of that, there is lack or less perfusion to the brain, less oxygen, and as a result of that, it's an impairment and destruction of the brain tissue. The vascular dementia can be the result of diabetes, hypertension, or plaque formation from hyperlipidemia. Is usually associated with high mortality rate. Fetal alcohol syndrome is a condition that leads to lower intellectual abilities, will affect up to 1.5 infants for every 1,000 live birth, and is a result of maternal alcohol intake during the pregnancy, while it's known that alcohol will crosses the placenta, and once the fetus is exposed to alcohol, the fetal development and especially the nervous system development of the fetus will be impaired. And Down syndrome is the most common type of chromosomal abnormality. Is caused by an extra chromosome, chromosome 21, or sometimes it may be caused by translocation of chromosome 15, 21, or 22. Question 1. What term refers to the higher thinking processes that allow for flexibility, adaptability, and goal directedness? The options are 1. Perception, 2. Memory, 3. Executive function, or 4. Reasoning. The correct answer is 3. Executive function refers to the higher thinking processes that allow for flexibility, adaptability, and goal directedness. Question number 2. What is the primary age group for cognitive impairment? 1. Teenager, 2. Young adult, 3. Middle age, or 4. Elderly. Correct answer, the primary age group for cognitive impairment is 4. Elderly. Question number 3. When a health condition leads to temporary or long-term impairments in cognition that is reversible with treatment, it is called 1. Dementia, 2. Delirium, 3. Amnestic, or 4. Aphasic. Correct answer is 2. Delirium. Delirium is a health condition that leads to a temporary or long-term impairment in cognition that is reversible with treatment.